Okay, hello, good evening. Today is our second discussion about colorectal surgery, eMRCS question bank. Let's start our session. Okay, Dr. Shi, you can start.
Okay. To embark on a laparoscopic appendicectomy and find an appendix mass. There is no free fluid and the patient has no evidence of peritonitis. Which is the best option? So C, place a drain laparoscopically and administer parenteral antibiotics.
Yes, Adrian. Yes. So what's your diagnosis here? What's this protocol called?
Oh, I forgot the name of the protocol.
Okay. So
it's
this is an appendix.
Sharon regimen.
Okay.
Oslo Sharon regimen.
Sharon. Yes.
Sharon.
So if you went for, and this is one of the benefits of laparoscopic surgery, because you first go with the camera, okay, and if you find any problem, you can go out and you have just a very minimum incision through the umbilicus, and you didn't do the operation. So before we can do ocean sharing maybe blindly, or sometimes when you do an open surgery and look like a mass, you try to manipulate the mass, you can't just put a drain and go out. But here with laparoscopic surgery, you can go for ocean sharing after you started your operation. Okay?
Yes.
Any appendix mass, you go for conservative treatment. Can anyone tell me what is the difference between appendix mass and appendicular mass?
Appendicular mass, it means the inflammatory process that occur after appendix. Appendicular, the mass, it may be any other
Anyone can clear it more?
I think appendicular mass, that small intestine and appendix entrapped with the omentum. But appendix mass may be a tumor or something like that.
Still no.
I think the appendix mass is within the appendix itself, and the appendicular mass is something which is from an organ, but it's just like the
the opposite of what you are saying. Okay, so appendix mass means a mass around the appendix, amalgamated appendix in the middle, and a mass like ileum, peritoneum, anterior abdominal wall, some small intestine, any organs contains the appendix inside. Okay, so it is an appendix mass, a mass caused by the appendix, inflamed and make amalgamation of organs and tissue around. Appendicular mass means a mass of the appendix. So it may be carcinoid, it may be abscess. Okay, so it is considered belong to the appendix. Like we say, gallbladder mass or colorectal mass means a mass concerning or belonging to the colorectal, or rectal mass, the same, or dermal mass. But when we say appendix mass, we mean that a mass contained within amalgamated tissue or organs around it. Okay, clear?
Yes.
Okay. Dr. Ajaye? Yes?
Dr. Rami.
Yes.
Yeah, I was just about I was just about saying the same thing. The appendicular mass, that's an inflammatory process following acute appendicitis, in which the omentum tries to wall off the inflammation around the appendix.
No, this is the appendix mass. Appendix mass means appendix caused a mass. Inflamed appendix caused the tissue around, like maybe intestine, maybe omentum, maybe fallopian tube, maybe other organs to stuck to it to make appendix mass. Appendicular mass means the appendix itself has a mass. Without you can remove an appendicular mass if you can find an appendicular mass, okay, like abscess, appendicular abscess, appendicular carcinoid, appendicular tumor, leiomyosarcoma, or something like it, you can remove it. But appendix mass, and you have to make sure of this, because I'm make sure, because before start of my residency I was confused about this till I make sure from, I don't remember the book, but this is appendix mass, like a mass amalgamated with other organs. Appendicular mass means a mass related to tissues of the appendix itself, from its name, appendicular mass. Okay, Dr. Zainab, sorry. You want to ask about anything?
No, okay, no problem.
Okay, so, okay, who's next? Who's next, Dr. Zainab?
Okay. 23 years old male present with bright red rectal bleeding that occurs post defecation onto the toilet paper. He has been suffering from severe pain associated with this. On external anal examination, there is a skin tag located on the 6 o'clock position, which of the treatment listed below is most likely to be helpful. Topical GTN. This case fissure. Fissure, anal fissure.
Fissure in anal, okay. Exactly.
Oh. Topical GTN, rubber band ligation, injection of oily phenol, Milligan-Morgan hemorrhoidectomy, Lourdes anal dilatation. For this case, using topical GTN.
Yes, exactly. And in UK protocols, not like us, we have an acute and chronic. Acute within 2 weeks, 3 weeks, 1 month. We can give some conservative treatment, after which we go direct for the, even if there is skin tag, we go direct for surgical treatment. But in UK, you find he starts even with a skin tag for a long time. He starts with GTN. If GTN failed, he go for botulinum toxin injection. Okay, to relax the sphincter muscle, the circular muscle around the anus. This is the protocol in UK. I didn't see surgery for anal fissure in all our scenarios. Clear?
Okay.
Okay, so Dr. Fatima, go.
28 years old male presents with painful bright red rectal bleeding. On examination, he is found to have a posteriorly sited midline fissure in ano. What is the most appropriate treatment? Topical GTN paste, sublingual GTN paste, anal stretch, advancement flap, tailored division of external anal sphincter. Again, topical GTN paste.
Yes, exactly. Clear and direct. Topical GTN. Okay, then Dr. Daffer.
During colonoscopy, yes, during colonoscopy, a patient is found to have a colonic cancer in the cecum and a 1 centimeter polyp which looking adenomatous in the sigmoid colon. What is the correct management of the sigmoid polyps? Undertaking snaring polypectomy, leave in situ until the cancer have been resected, perform a hot biopsy, perform cold biopsy, resect the sigmoid at the same time of the cancer screen. And the thing is snaring polypectomy. Right? No, not IB.
Snare polypectomy. Why you do snare polypectomy?
To diagnose it.
What is the difference between snare polypectomy? There is choice number A and C and D. Hot biopsy and cold biopsy.
I don't know.
Why you didn't choose hot biopsy or cold biopsy?
I don't know about it.
So the three are wrong because
So
the three are the same. It's B. Okay. So the scenario here is just, okay, it's B. Leave in situ until cancer has been resected. Why you are going to do histopathology, and you already found a cancer and you diagnosed a cancer in the cecum. So you already are going for an operation, okay? You're already going for an operation. And he tell you it is 1 centimeter polyp and it looks adenomatous. You already have a cecal cancer and you are going for operation to remove the cecum. So it is preferred not to remove this mass until you remove the cecal cancer, okay? And mix with safety margin, and you will do histopathology and your margins are free and everything is free. And then you start to remove a smear and makes the patient maybe susceptible for seeding or something like this. So it is preferred not to remove it, okay, until you just remove the main cancer you already diagnosed and you already did see by the colonoscopy, and then go to treat the smear according to the histopathology. Is the colon have a type of cancer that is have a high rate of spreading or familiar or some like FAP syndrome, so all the colon you want to remove, it all will depend on what is the histopathology of your specimen of the cecum, okay? So here, what is right? When a cancer has been identified, already you identified cancer during endoscopy, it's safer to avoid undertaking polyp intervention as there is a high risk of seeding. Okay?
okay.
Next question. Who's Dr. Yazid?
An 86-year-old man is admitted with passage of large volume of blood per rectum. On examination, he has tachycardia. His abdomen is soft, although he has marked dilated vein on his abdominal wall. This portal hypertension. Proctoscope reveal large dilated vein with stigmata of recent hemorrhage. What's the most appropriate treatment? It's A. Intravenous triplecycline.
Okay,
Rectal varices.
Yes, it is a case of portal hypertension with varices or maybe other cause of abdomen tachycardic, dilated veins, abdominal wall, proctoscope reveals dilated veins, stigmata of recent hemorrhage. So you'll put this terlipressin. This is sound like a vasopressin used to decrease the portal hypertension. Okay. Just this is a unique scenario, and this is a unique drug. You'll find no other question mimics this scenario, by the way. Next question, Dr. Ihab. Dr. Ihab. Unmute.
Yes. A 43-year-old male has been troubled with symptoms of post-defecation bleeding for many years. On examination, he has large prolapsed hemorrhoid. Colonoscopy show no other disease. What is the best course of action? Injection with 20% phenol, injection with 80% phenol, rubber band ligation, excisional hemorrhoidectomy, hemorrhoidal artery ligation. Has been troubled with symptoms of post-defecation and rubber band ligation. Or excisional hemorrhoidectomy.
Okay, this patient has male pain with signs of post-defecation for many years. When he has a large prolapsed hemorrhoids. Yes, this is large hemorrhoids. Will you go for rubber band ligation?
So for excisional hemorrhoidectomy?
Excisional hemorrhoidectomy, yes, exactly. We go for rubber band ligation in minor cases or first and degree types of hemorrhoid, and it gives us the same results like hemorrhoidectomy or injection, but it is not a common practice. But in large hemorrhoids, you have to remove it with excisional hemorrhoidectomy. Okay, so we have two scenarios of hemorrhoids. If it is small hemorrhoids, we'll go for band ligation. If it is large hemorrhoids, we'll go for excisional hemorrhoidectomy. We have two scenarios for hemorrhoids.
No rule for injection for these cases, totally?
No, we find nothing. No scenario comes with injection here. It is not a common practice, by the way. Okay, next question. Next question, Dr. Again, start with Dr. Shi.
A 78-year-old lady is admitted with a lower GI bleed, and on investigation with a CT angiogram is found to have bleeding sigmoid diverticular disease. She is also otherwise well, and apart from tachycardia, she is stable. What is the most appropriate course of action? Laparotomy and Hartmann's procedure, laparotomy, sigmoid colectomy and colorectal anastomosis, colonoscopy and application of endoscopic clips to the area, conservative management with close observation, laparotomy and subtotal colectomy. I think it's D, conservative management with close observation.
Yes, exactly. Here is we have an old patient, almost 80-year-old lady. Just attack of lower GIT bleeding and investigation really by the CT scan with contrast with lower barium or gastrography contrast. You found that she has sigmoid diverticular disease. By the way, most old patients, because of chronic constipation, if you did a survey with a CT, you'll find maybe 30, 40%, maybe 50% have some degree of diverticular disease, something like aging and chronic constipation, and this is just lifestyle. You will have this. I have seen many patients with diverticular disease accidentally discovered they have just have pelvic or right or left iliac pain, discomfort for a long time, and with CT we discover that like it is a diverticular disease. By the way, diverticular disease is very rare to go for any cancer or malignancy. Just sometimes if it is in early life, you're afraid from stricture, you're afraid from perforation, you're afraid from many problems, but in old age it's very common. And as a patient is stable and he wants to tell you, you know, in the scenario, he wants to tell you go for conservative. He's fair enough to tell you she is otherwise well, apart from tachycardia, she is stable and everything. So were you going to do a laparotomy for a stable patient? Okay. Is it logic to go for laparotomy?
No.
Okay. It is logic to do a colonoscopy for a patient who has diverticular disease and you already diagnosed with CT? No. Colonoscopy may have more hazards for her. Okay. So the logic here to go for conservative treatment. You know what is Hinchey classification? Hinchey classification is the classification for diverticular disease. Sometimes if he will not ask you about the stages, but I have a question in my exam, he asked me like a silly question. What is the name of the classification of this scenario? And I really, it wasn't Hinchey, but it was a strange scenario about maybe cardiac surgery or something like this. And he gave me about 4 or 5 names, strange names, first time to see in the exam. Okay, so in some classification, just to try to catch the name. So Hinchey classification is a classification for diverticular disease, which starts with small paracolic abscess, then it is leaked to make a pelvic abscess, then the abscess will rupture to do a pelvic, a purulent peritonitis, and then it will be more than abscess and it will be fecal peritonitis. Even the classification is easy to know if you want to do, okay? The first one, we go conservative treatment, Hinchey 1. Hinchey 2, we go maybe open or interventional radiology percutaneous drainage for the pelvic abscess. For 3 and 4, we go for laparotomy and Hartmann sometimes. Okay? Clear? Or I say again? Hello?
Yes, okay. For me, it's clear.
I think, yes, clear, I think. So Hinchey classification for diverticular disease. Okay, next question. Dr. Zena?
Dr. Rami.
Yes, go.
I was muted. I don't know why.
I know.
73, okay, 73 years old lady, present with constipation and no organic disease is identified on investigations. Which of the following types of laxative works by direct bowel stimulation? Magnesium sulfate, lactulose, potassium sodium citrate, methyl cellulose, sina. I don't know. I don't know.
This is pharma, Sina. Okay. No, it like this, Sina. This is the one and common question and sometimes come in the exam and has no other mimic question or related question. So the best, he will ask you about an old lady needs laxative by direct bowel stimulation, you'll go for Sina. Others are not common in the exam, okay? We're just passing pharma question. Okay, next question, Dr. Fatima. Also muted. Yes, I'm mute, okay.
Yeah, it's 32 years old man is diagnosed as having a carcinoma of the cecum. On questioning, his mother developed uterine cancer at the age of 39, and his maternal uncle died from colonic cancer, age 38. His older brother developed a colonic cancer with microcystic instability, age 37. What is the most appropriate operative treatment? Limited ileocecal resection, right hemicolectomy, extended right hemicolectomy, procolectomy, subtotal colectomy. So do we have to do with go with it's on the right side, so on the right side we have to go like a full right hemicolectomy or procolectomy?
Okay, what is the relation here if he wants you for right hemicolectomy? What's he want to tell you? His mother developed uterine cancer at the age of 30, 39, 35. His maternal uncle died from colonic cancer at the 38, something like this. Don't you see something like he want you in this age? He have many. Yes.
I'm sorry.
Okay, he wants to tell you this is a syndrome and it is a familiar or inherited syndrome in this family, that most of them have cancer in in about 13 in the 4th decade of life. Okay, this is what's called Lynch syndrome. Okay, he has his mother and one of his first relatives died. His mother, it is related to endometrial or uterine cancer, and he has one of his first relatives died from colon cancer at young age. And that's why when in each scenario, history or communication skills in part B, any patient just mention his mother, sister, or any relative died from cancer, it is one of the marks and one of the checklists. You have to ask him about at which age. Okay, so here he wants to tell you in this patient, it's very common to have a colon cancer. So if you just found a carcinoma in the cecum and you remove, he will most probably, he will need to, or he will have another cancer in his colon. So what we'll go for, you'll go for pan-proctocolectomy. Okay?
Yeah.
Okay. Let's see what is Lynch syndrome. Okay, we have some syndromes which is important here. We have what is called familial adenomatous polyposis, and I think we did talk about this last time. This is a familial problem due to a mutation in APC gene, very important APC gene, and it will have more than 100 chronic adenomatous by the age of 20, 25, something like this. What you do for this patient, you start with colonoscopy at the age of 12, okay? And if you didn't find any polyps, you'll do another one after 5 years. Till now, this protocol. And if you find polyps, you'll start to follow up this patient. By the age of 25, this patient should have a pan-proctocolectomy, okay? Because this patient at the 4th decade, he will 100% have cancer colon, okay? FAP or familial adenomatous polyposis is very common associated with duodenal polyps. About 90% have duodenal polyps and about 50% has fundal polyps. So what you need in this one, you need to just a minute, please. What I'll make here, that's very important. FAP, APC gene, okay. Patient should have subtotal colectomy, no total colectomy by the age of 25. Duodenal polyps about 90%, fundal polyps about 50%. Okay. This is very important concerning FAP syndrome. This other one known, it's very important, Peutz-Jeghers syndrome, and this is a syndrome is common in young age. Okay, and it is associated with, yes, bony tumors, especially in the face, and desmoid tumors. Okay, so he will tell you the patient has some pigmentation and pigmentation on the mouth, and have some polyps, and have big lower jaw is prominent, and the upper and the eyebrow or upper orbital ridge are prominent, and have some desmoid tumor. This is a case of Peutz-Jeghers syndrome. Okay, he will not ask about anything more than this. Associated risk cancer of gastric, increase the risk of breast, ovarian. No. He just Peutz-Jeghers syndrome, polyps plus pigmentation on the mouth, and have some bony and prominence in the face, and bony tumors and desmoid tumors as well. Yes, this is Codwin syndrome. Yes, what is asked about Codwin syndrome? Cowden syndrome, Cowden disease is P10 gene. Okay, P10 gene. This is very common to ask about the gene of Cowden disease. HNPC, or hereditary non-polypoidal colorectal cancer. This is what's called Lynch syndrome. Okay, I think it is P53. Okay, I think so, because this is the DNA germline mutation of DNA mismatch repair gene, which is P53, and it is associated with endometrial cancer and colorectal cancer. It's a familial condition. Colonoscopy at the age of 25, consideration of panproctocolectomy. Panproctocolectomy, extracolonic surveillance recommended. Extracolonic cancer, and it's very common with extracolonic cancers, like what we said, endometrial and gastric cancer. Okay, you just take care here that gastric cancer is 10%, but with FAB and APC gene, it was about 50%, and duodenal cancer, it was 90%. Okay.
Yeah.
This is the most important thing. I didn't see it here, but I think I did see in recalls and in past tests as well. But here I didn't find any question about this, but this is the most common, and sometimes you will face this in part B. Next question.
A 62-year-old man is admitted to having rectal carcinoma. Follow diagnostic workup. No metastasis disease is identified. The tumor 2 centimeters from the anal verge. On MRI, lesion is T2 and 0. Which of the following represented the correct cancer course of action? Procedure abdominal perineal excision of the colon and the rectum. Undertaking low anterior resection on loop ileostomy. Undertaking hemorrhoidectomy, Hartmann procedure of a radical external beam radiation following abdominal perineal resection. Of a radiotherapy, radical radiotherapy followed by anterior resection and loop ileostomy. So proceed by the 2 cm from the anal verge. So proceeded for abdominal perineal resection of the colon and the rectum. A.
Okay, why we didn't do lobe colostomy here?
Because we cannot preserve the stoma.
Again, why we didn't choose B here?
Because
Low
it's
anterior
lower down.
section.
Because it's lower down tumor.
Okay.
When remove the oral rectum, we cannot anastomosis to.
Okay, so I'm just asking about another thing. If this patient is obstructed or not obstructed. This patient is not obstructed, and I did a full diagnosis, and I did MRI, and I did the staging, and I'm ready to do the definite treatment. And as we said last time about tumors in the rectum, okay, tumors in the rectum, we have two choices. If it is just 10 centimeters, if it is less than 10 centimeters, and sometimes now 8, I can't preserve the anal canal, and I'll go for abdominal perineal. But if it is above 10 centimeter, I can preserve the anal canal for anal anastomosis or anocolic or ilioanal anastomosis. So I can preserve the anal canal and do what is called low anterior resection. Clear?
Yes.
So I have two tumors. If below, I just do digital rectal examination or lower colonoscopy. If it is less than 10 centimeter, I can't preserve the anus, and I'll go for abdominal perineal. If I more than 10 centimeter, I can preserve the anal canal and to make the anastomosis with the colon or the ileum. And now with the advance of circular stapler, we can do even less than 10 centimeter up to 7 or 8 centimeter. We can do stapling and we can preserve the rest of the inner canal. Clear?
Yes, it's clear.
Okay, next question. Dr. Abu Yazid. Okay.
24-year-old woman presents with long history of obstructive defecation and chronic constipation. She often strains to open her bowels for long periods and occasionally notices that she has passed a small amount of blood on examination. She has an indurated area located anterior approximate 3 centimeter proximal to anal verge. What is the most likely diagnosis? It's the solitary rectal ulcer syndrome.
Exactly.
Sorry.
No problem. Okay, yes, exactly. This is induration area located anterior, 3 centimeter from the inner verge and presented with bleeding and chronic constipation. So the diagnosis solitary rectal ulcer syndrome, and it is not a very common disease and should be biopsied for confirmation of its origin. Okay?
Yes.
Okay. Next question. Dr. Ihab.
Yes.
Okay.
A 34-year-old man present with symptoms attributable to fistula in ano. He is examined in the lysotomy position. The external opening of the fistula identified in the 7th o'clock position. At which of the following location the internal opening most likely to be identified? I think, as you said yesterday, this one will be at 6 o'clock.
Yes.
As yesterday, above and below, yes. From above, it will be directly to the same opening, and from down, it will take like a curve like that to open in the midline. This is from you yesterday.
Okay. So
So 6
our
o'clock.
answer will be
E.
6 o'clock. Yes, exactly. This is what's called Goodsell's rule. Goodsell's rule. Above, from 3 to 9, above it will go direct for the same direction of external opening, but on the below it will go for the midline at 6 o'clock.
Yes.
It's clear for all, or anyone wasn't with us yesterday? I think it's here again. Okay. Clear for all. We just explained it yesterday. Okay, next question. Dr. Shi.
A 19-year-old man presents with painful rectal bleeding and is found to have an anal fissure. Which of the following is least associated with this condition? D. Sickle cell disease.
Okay, it's not a very common question, by the way. So he's asking here about fissure, which most diseases is very common with fissures. So tuberculosis, yes, make ulcers and can make a fissure. Syphilis can make ulcer to mimic a fissure. Leukemia, I don't know, I think. And Crohn's disease for sure can make an ulcer and a fissure in the GIT from mouth to anus. Okay, so sickle cell disease, we didn't hear about any anal ulcers or anal fissures related to sickle cell disease. Next question, Dr. Zaina.
Okay. 53 years old man present with a full thickness external rectal prolapse. Which of the following procedures would be the most suitable surgical option? Rectopexy, Delorme's, Altomere's thresh tape, abdominoperineal excision of the rectum. For this case, best is rectopexy.
Exactly. This is a full thickness sliding of the mucosa of the rectum. Okay, and maybe it is not only the
Patient
mucosa, sorry,
thick,
this is a, and this is a full thickness external rectal prolapse. Partial
okay.
thickness is prolapse of mucosa only. Full thickness is mucosa of the wall of the rectum. Okay, according to my information from my master, partial thickness you can remove it like hemorrhoidectomy or excision and suturing, but full thickness you can't remove the wall of the rectum. You have to rectopexy to the sacrum to fix it to the sacrum again. So rectopexy will be the best treatment for full thickness external rectal prolapse. Okay.
Yes.
Dr. Rami, is there any other scenario about the rectal prolapse?
No.
This is the most common one.
Yes. Till now, no.
Okay.
If you want to know about Delorme, and I didn't see even Enrico. So keep it. He wants you to know rectopexy. Full thickness rectopexy. If partial thickness, it will go for just excision and suturing of the prolapsed. Sorry.
Ultimate.
Ultimate. Maybe I was confused which one of it. But this is ultimate means just excision. Sometimes with stapler, you remove the redundant mucosa and reanastomose again. Only the mucosa. But in full rectum, you have to make the wall of the rectum back to its normal position. Okay, next question.
Patient has an appendectomy and a 1.2 centimeter carcinoid tumor is identified in the tip of the appendix. What is the most appropriate management? Watchful waiting, discharge, right hemicolectomy, limited ileocecal resection, and radioisotope scan. It's a very small carcinoid. So,
yes, and at the tip?
Yeah, at the tip. So we cannot do hemicolectomy, we cannot do limited ileocecal resection. So maybe watchful waiting?
For what?
But like, it's a tumor.
You already make a histopathology because you have the result of histopathology that is identified. It is 1.2 centimeter carcinoma at the tip. That means that your margins is free. So you will discharge the patient. Most commonly recurrence will. By the way, it is not, I think, watchful waiting is very close in our daily practice about discharge. So discharge the patient until you tell him that you have a carcinoid tumor in your appendix. So just take care if it happened again. So watchful waiting, I think it's very close decision like this.
Less than 1.5 cm.
Sorry?
If mass less than 1.5 سم
2
لا
centimeters.
لو هي الماس اقل من 1.5 less than 1.5 سم no further treatment, only appendectomy. If more than that, you will go for right hemicolectomy again.
Okay, according to our scenario here is 2 centimeters.
Oh, okay.
Okay.
So appendectomy.
Okay. Yes, but in the tip, but if it is small in the base, you will go for right hemicolectomy.
In base, right hemicolectomy.
It is this, at the base, right hemicolectomy, whatever the size. If it is at the tip or less than 2 centimeters, you just go for appendectomy and discharge the patient. Okay, Dr. Dafir.
Yes. A 30-year-old lady presented with painful bright reading bleeding that occur post-defecation. Digital rectal examination is too uncomfortable for the patient. Painful inspection show prominent posterior skin tag. What is the best course of section? Arrange for removal of the skin tag, arrangement for hemorrhoidectomy, prosigmoid, topical daltiazim, yes. Injection of 25 plenol, arrange for sphincterectomy, no. So prescribe the topical diltiazem.
Okay, diltiazem, like the GTN, it is more, all of them is calcium channel blockers and dilators and arterial dilator. So will be the same like GTN, topical diltiazem. Okay. Till now, all patients had topical diltiazem or GTN. The same, by the way. Okay. Next question, Dr. Abu Yazid.
Male present, 31 old, male present with recurrent episode of knife-like pain with his rectum. On examinations, there is no abnormality to find either proctoscopy or palpation. What's the most likely diagnosis? We mentioned
By
it
exclusion.
yesterday. Procteria focus.
Yes. Yes. Proctalgia, fugex. Okay. So by exclusion, if even you don't know, you found no abnormality. So
Fissure, no
fissure,
pain,
you know,
no painful
fistula,
anus,
fish. No,
fistula
fissure.
discharge.
This is, you find the abnormality already. You will see the
Yes,
fissure,
I
you will
know.
see the fistula, you will see the cancer, and you'll see the abscess, or you feel the abscess. But no abnormality.
No
So by
abnormality.
exclusion,
Yes.
yes, exactly. Okay. Next question. Dr. Ihab.
Yes. A 20-year-old man is admitted with bloody diarrhea. He has been passing 10 stools per day. Hemoglobin is 8. Albumin 20. Stool culture negative. Evidence of colitis and endoscopy. He has been on intravenous steroid for 5 days and he has developed a megacolon. His hemoglobin is falling. Inflammatory marker is static. What is the most appropriate course of action? I think this is subtotal colectomy and ileorectal anastomosis. Sorry, and endoileostomy. This is like an emergency in the Crohn's, I think, or ulcerative colitis.
Yes.
Sorry, we will go for subtotal colectomy
Yes.
and endoileostomy.
Yes, exactly. Okay. Yes, you're right. Okay, here is a scenario: is patient young age, bloody diarrhea, 10 episodes per day, hemoglobin start to fall, albumin fall, stool culture is negative, so it is not an infection. Evidence of colitis and endoscopy, so there is ulcerative colitis. Intravenous steroids for 5 days and has now developed megacolon. His hemoglobin is falling again and the inflammatory markers are static. What is the most appropriate course of action? So, any status patient with fulminant condition or exacerbation of acute condition of ulcerative colitis or Crohn's disease, you have to go first for 5 days treatment with steroids, intravenous steroids for 5 days. If the patient failed medication or the medication failed or the patient exhibited complications like megacolon and hemoglobin is falling, you have to go for subtotal colectomy. You can't do total colectomy for an emergency case. Okay, so as an emergency, subtotal and endoileostomy is the treatment of a choice for emergency case. But if this patient is stable and he has recurrent episodes and he you give the medication for 5 days and he now is stable, you can schedule the patient for total colectomy or proctocolectomy with ileoanal anastomosis or ileal pouch or J pouch anastomosis. Okay, but in emergency, subtotal plus endoileostomy. Okay.
Okay.
Pan-proctocolectomy shouldn't be performed in acute unwell patients. Loop ileostomy is not conventional. We don't do loop ileostomy. Not a common practice. Okay, next question. Dr. Shi.
A 23-year-old lady has suffered from diarrhea for 8 months. She has also lost 2 kg in weight. At colonoscopy, appearance of melanodisculi are identified and confirmed on biopsy. What is the most likely cause? So, C. Laxative abuse.
Exactly. This is just a pharmacology question, like some of the side effects of laxative abuse is what's called lipofuscin-laden macrophage that appears like brown pigmentation of the colon. Just laxative abuse will give you some brown dots in the colon, like looks like a pigmented colon, melanodisculi. Okay. Also, question like has no related question as well. Next question. Dr. Zena. Dr. Zena.
Hi, Dr.
Go.
Okay. 73 years old lady admitted with brisk rectal bleeding. She is otherwise well and bleed settles. On examination, her abdomen is soft and non-tender. Elective colonoscopy shows a small erythematous lesion in the right colon, but no other abnormality. What is the likely cause? Diverticular bleeding, angiodysplasia, colonic cancer, ischemia, infective colitis.
What do you think about this erythematous patch? From its name.
هي ماشية أكتر مع الأنجيوديسبليزيا.
Exactly. From its name, it is an erythematous patch, and it's very common in old age, having just one attack of brisk rectal pure blood bleeding. So if diverticular disease, we said will come with dark blood and with colonoscopy, yes, some sort of abdominal pain. Post colonoscopy, you'll find diverticular disease of the sigmoid. Chronic cancer, you will see it is not an erythematous lesion. Chronic cancer, you will see a cancer. If it is bleeding cancer, I think it will be advanced cancer. Ischemia and infective colitis will give another picture. Ischemic picture of the colon. It will be black, blue color, something like this. Infective colitis will give you different complete pictures. Exactly. So from erythematous lesion, smaller erythematous, it most commonly come with angiodysplasia. Okay, next pharma question, Dr. Fatima.
A 55 years old man develops an acute colonic pseudo-obstruction following laminectomy. Despite correction of his electrolytes and ongoing supportive care, he fails to settle. Which of the drugs listed below may improve the situation? Buscopan, neostigmine, metoclopramide, mepivarine, sodium bisulfate. Bicosulfate, sorry. So I have no idea. But like we cannot give Buscopan,
Buscopan antispasmodic.
Yeah.
Buscopan metoclopramide is antiemetic. Okay. Pharma question. Just do it. It is neostigmine. This is the antidote for acetylcholine. Okay. So so neostigmine it is used, and I think it is not given except in something like HDU or ICU. Chronic pseudo-obstruction produces generalized chronic contraction, and its onset is usually rapid. Okay, neostigmine. Chronic pseudo-obstruction not improving. Okay, go for neostigmine. What is the name of chronic pseudo-obstruction?
Only
has
if
a specific. Yes. Olive C syndrome. Yes. We will.
Again,
Sorry?
Rami. What is the name?
Oh, wait. Second, please.
Oh, Ogilvy syndrome, yeah.
Ogilvy syndrome.
Yeah.
Ogilvy syndrome. Ogilvy.
Okay.
Usually happen in old bedridden patient. Is that the one?
Sorry?
It usually happens in old and bedridden patients. Is that the one?
Sometimes, yes, sometimes happens post-operative. Sometimes happen without any cause, like chronic pseudo-obstruction, an old patient or an addict patient, or an patient have neurological symptoms, neurological deficits, or some sort of a neuropathy. Has many causes of Ogilvy syndrome. Okay, next question.
who's
Who's turn? Dr. Abu Yazid.
It's Dr. Duffer turn, I think.
okay? For
Dr.
me,
Duffer, okay, go, sorry.
an 83 years old man admitted with the acute surgical take. His presenting symptom of painless profuse rectal bleeding and dark blood. His medical history compromised previous TIA, for which he clopidogrel and statin. What is the most likely diagnosis? Meckel, diverticulum, colonic cancer, diverticular bleeding, ischemic colitis, and diverticulitis. It is ischemic colitis.
Ischemic colitis, he presents with symptom of painless, profuse rectal bleeding. This medical is compliant with previous TIA,
Yes.
for which he takes clopidogrel and statin.
Ischemic colitis associated with severe abdominal pain.
Exactly. And most will be fresh bleeding, not dark blood.
Maybe diverticular bleed then?
Yes.
Yeah.
I told you, here is a scenario, an old patient, and he tell you he passed dark blood, painless dark blood. It will be mostly diverticular disease. Ischemic colitis, severe, the triad of abdominal pain, passage of massive blood, mostly will be fresh blood, followed by fainting or collapse. Okay, this is the scenario of ischemic colitis, by the way, or what's called? Yes, ischemic colitis. Ischemic
Following
colitis.
aortic
Okay.
repair or something.
Yes, any cause following AF. It happens very common. It happens in old patient admitted in ICU with AF. You found the patient, go toilet, or just pass a motion of blood, severe abdominal pain, motion of blood, bloody rectum, and start to faint and shock and hypovolemic. This is a very common condition, happens in ICU for all patients suffering from thrombotic disease or mostly with AF. Okay, this is the accurate description for ischemic colitis, by the way. If you see a patient in the ICU, walking in the ICU or just moving to the toilet and having shooting very massive amount of blood, you will never forget this this situation in your life. I did see it many times in ICU. This patient with ischemic colitis or acute embolic colitis. Okay.
Yes.
Next question.
55-year-old man is found to have carcinoma in sigmoid colon on a screening colonoscopy. How should this be staged? MRI, liver MRI, CT scan. I can treat. The question is changed. I can treat. Yes.
No.
It's C, CT scan of chest, abdomen, and pelvis.
Yes, exactly. Diagnosis of colonic cancer. We'll go for CT scan, chest, abdomen, and pelvis. Okay. For rectum, we go for MRI. MRI rectum and CT abdomen and chest.
Pelvis, chest.
Okay. So MRI, we do it for rectum.
Staging.
And yes, and CT for other. Mostly as a erythroproteinuria and organ in the pelvis, so MRI will be more accurate for it. But the abdomen and chest is fixed with CT for any staging condition. Okay?
Okay.
Next question, Dr. Ihab.
Okay. Which of the agents listed below is most likely to help 22-year-old lady with severe perianal Crohn's disease and multiple anal fistula? The acute sepsis has been drained and ceton are in place. She's already receiving standard non-biological therapy. I think for this case, we are giving infliximab.
Exactly, infliximab, one of the biological agents we use to treat ulcerative colitis and Crohn's disease, inflammatory bowel disease, infliximab, adalimumab, and something more I can't remember.
But for the others name, this one we should know also, this cetuximab for what?
No. You can know the trastuzumab because you will face it in breast cancer, one of the biological agents we use for treatment of HER2 positive breast cancer.
Okay.
Okay, so what you want to know here is, I think it is illustrated with, yes, adalimumab, infliximab, forget etanercept. This is all for Crohn's and rheumatoid, and sometimes for ulcerative colitis, sometimes, but it's inflammatory bowel disease or Crohn's disease. Okay, trastuzumab, HER positive cases in breast cancer. Okay, imitanib, you just know it is a tyrosine kinase inhibitor. Okay, just know it. And we use it for GIST, gastrointestinal stromal tumor. Okay, so adalimumab, infliximab, etanercept, it is for Crohn's disease. Trastuzumab is HER2 positive breast cancer. Okay, and imitanib, it is a tyrosine kinase inhibitor. You always ask about the action. Tyrosine kinase inhibitor, and we use it in GIST syndrome, GIST tumor of the GIT, gastrointestinal stromal tumor. Others we has no sone. Tamoxifen for estrogen positive, yes, exactly. Next question. Who's there? Dr. Shi?
I think it's my turn. Yeah. A 78-year-old man has undergone a hemiarthroplasty for an intracapsular hip fracture. Postoperatively, he develops electrolyte derangement and receives intravenous fluid. Over the next 24 hours, he develops marked abdominal distension. On examination, he has a tense tympanic abdomen, which is not painful. A contrast enema shows flow of contrast through the cecum and through the ileocecal valve. What is the most likely cause? So 78-year-old D or volvulus?
It's not painful.
Oh yeah, it's not painful.
Not painful. Contrast enema show the flow throughout the cecum. And
Then
with the
by-
contrast
by-
enema,
Yes.
the contrast enema passed
Through the
from the
cecum.
anus till the ileocecal valve. So you have no organic obstruction and you have
Yes.
no organic cause. So by no organic cause, you exclude 4 of these choices.
Maybe by exclusions A.
Yes, Ogilvy syndrome. Okay, painless abdominal distension is Ogilvy syndrome. Painless, tympanic, tense tympanic abdomen, old age, post-operative, due to maybe electrolyte imbalance or something like this. It is Ogilvy syndrome. If it is painful, diverticular disease will give you, here is the contrast enema, show flow contrast through the cecum and through the ileocecal valve. It is completely passed, okay, without any. If he say, he can see, he can tell you some contrast material in the sigmoid with vesicles or some print or something like this. No, he just tell you that it completely filled the colon. Malignant structure, you will see volvulus will not pass. Adhesion obstruction also will not pass. The contrast will not pass. This is the only one here is the pseudo obstruction is Ogilvy syndrome. Mostly due to electrolyte disturbance, as he said here. Okay. Next question. Dr. Zaina.
Okay. 68 years old man present with ulcerative colitis is admitted with an exacerbation. You are called to see him because he is having a brisk dark perirectal bleeding. He has been on intravenous hydrocortisone for 5 days. The gastroenterologist has done an I think this is upper endoscopy or what?
IGD, yes.
To exclude a
Esophageal
duodenal ulcer.
gastroduodenoscopy. Yes.
Okay. To exclude a duodenal ulcer. This was normal. What is the best course of action? Subtotal colectomy and end ileostomy, pan-proctocolectomy and end ileostomy, colonoscopy, CT angiogram, flexible sigmoidoscope. This case ulcerative colitis وفي هنا active bleeding فالبيست تريتمنت في الامرجنسي كيسز subtotal colectomy and end ileostomy.
Perfect. So this patient is 70-year-old ulcerative colitis. We give the trial of 5 days hydrocortisone. UK protocol, you have to pass the 5 days hydrocortisone before you go for the surgical treatment. If failed, go for surgical. So he have to mention here. Questions are fixed and scenarios are fixed with their protocol. He wants you to know their protocol by heart. So
okay.
After 5 days, no response, and just exclude because it's dark bleeding. You did upper endoscopy, just exclude. It may be something like a duodenal or something like this, and it is negative. The other thing, you can't do lower endoscopy for patients with heavy bleeding. So this is an emergency case of bleeding, and you diagnose with ulcerative colitis. So you can go for subtotal colectomy and end ileostomy, as we agreed. This is the emergency treatment for inflammatory bowel disease, not responsive for steroid treatment for 5 days. Okay. Fix the scenario, I think so. Next question.
21 years,
Fatima.
21 years old lady presents with a 6 months history of an offensive discharge from the anus. She is otherwise well, but is increasingly annoyed at the need to wear pads. On examination, she has small epithelial defect in the 5 o'clock position, approximately 3 centimeters from the anal verge. What is the most likely cause? Fissure in ano, fistula in ano, external hemorrhoid, squamous cell carcinoma of the anus, and protactasia fucus. So it's a fistula because it's for 6 months and he has to wear the pod.
Yes, exactly. Offensive discharge from the anus. So it is something like infection, abscess, or fistula, or incontinence. Maybe. Let's go for here. Fissure in ano, offensive discharge. No. Hemorrhoids. No. Proctalgia fugax, just pain. Squamous cell carcinoma of the anus will not give offensive discharge. And there is an epithelial defect in the 5 o'clock position, approximately 3 centimeters from the anal verge. And this is what he wants to tell you. This is an external opening of an fistula. Okay, so this is a fistula in anal. Okay.
Yes.
Dr. Rami.
So where we can find this is the epithelial defect in the 5 o'clock, 3 centimeters from the inner verge, where we can find the internal opening
In the 5.
of the fistula.
In the 5.
The same. No, 5.
Right?
5, 1, 4, 2, 3, 5. Yes, 6 o'clock. Yes, exactly. Who said 6 here?
Me.
Yes, all said 6. Dr. Yazid, Dr. Mumtaz, Dr. Salahuddin. Yes, 6 o'clock. Yes. So you'll find the opening and 6 o'clock. Yes, internal opening. Yes, here is the good cells. Yes.
Can I ask a question about the treatment of this fistula?
Treatment of this fistula depends on the level.
Yes, I mean
Sorry?
the different scenario for the treatment of the fistula.
You will not have the different scenario for treatment except for a high fistula. A high fistula, you go for seton, and a low fistula, you will go for lay down fistulotomy and lay open. You just open the tract. If it is just less than 1 centimeter and it is subcutaneous, and you can feel the external and the internal opening with one phalanx, something like this. You just probe the fistula and then lay open, means open deroofing, and you can remove the tract by curettage or something like this. In high fistula, you go what is called seton. Seton, okay? And some fistulas very high, and this is out of our scope, very high fistula. You can go up to colostomy and Hartmann till you relieve the fistula. The fistula, as there is drainage through the fistula, and as long as there is fluid and fecal matter draining through the fistula will not close. What they do in very high fistula, sometimes the fistula is in the rectum. You can find it in the rectum, okay? They do a colostomy and Hartmann. So they close the drainage from the fistula for 3 months till it is closed, or you could treat it with any procedure. Sometimes they inject some sclerosing materials. Now there is a fistuloscope can be advanced through the fistula to ablate the fistula, and after this they can revise the colostomy again after 3 months, so the fistula is closed. It is out of your scope, and you I didn't see any question even in records about this. Okay.
Okay. Thank you.
Okay, who's next?
Me.
Yes, go.
A 77-year-old man admitted with the large bowel obstruction and investigation with abdominal CT scan is found to have obstructive cancer in the sigmoid cancer. What is the most appropriate action? Laparotomy, sigmoidectomy, and formation of end colostomy, laparotomy and loop colostomy, laparotomy and loop ileostomy, laparotomy and high anterior section colorectal anastomosis, and palliative. So هنا about it is easy. It is doing a loop colostomy.
This is a tumor in the sigmoid,
Yes.
and he is a obstructed patient.
Yes.
Okay.
So I will do.
So
I relieve the obstruction.
yes.
Laparotomy and loop of colostomy.
Okay. Again. Just remember again. We said on the right side we remove the tumor and anastomosis.
Yeah.
On the left side and sigmoid, we remove the tumor and end colostomy. In the rectum, we just do a loop colostomy. Clear?
Yes.
So what's your answer?
Aye.
Exactly. Again, I'll use your illustration diagram of yesterday.
Yes.
You did this and this, okay?
Yes.
Here, remove and anastomose. Here, remove and end colostomy and Hartmann. Okay? Here, we just leave it and do a loop colostomy. Clear?
Yes.
Okay. This is their protocol. Maybe it is different from our protocol, but we have to follow laparotomy, sigmoid colectomy, and formation of a colostomy. Loop colostomy is only for incomplete diagnosis of rectal cancer. Okay?
Okay.
When to do ileostomy, Dr. Rami? Sorry, ileostomy.
Ileostomy in emergency cases from ulcerative colitis or Crohn's disease, and the patient is not responsive, you do pan-proctocolectomy and end ileostomy, or subtotal colectomy. Subtotal colectomy means that you go from the 10 centimeter from the ileum, all the right, all the transverse, most of the left, and as long as you go for the sigmoid, and just close it like this, because the rectum, any operation in the pelvis is a very big operation and needs a long time and needs the patient is fit. So you go as long as you can go to the sigmoid and do a loop ileostomy.
So in the large bowel obstruction, no rule for the ileostomy?
No rule for ileostomy. Completely no rule.
Okay, thank you.
Okay. Obstruction, you're talking about obstruction. You're not talking about a cancer.
No, I'm talking about obstruction in the large bowel. No rule for the ileostomy.
No rule for ileostomy for obstruction of the large bowel, because you have the ileocecal valve. You have the ileocecal valve. If you did ileostomy and the air, you have to, it should be an incompetent ileocecal valve, so you can relieve the obstruction by ileostomy. You understand? You have the ileocecal valve working as a gate. So any air in the colon, it's very difficult to go back to the ileum to be relieved.
Yes.
Okay.
Yes, okay.
In your information, for your information, okay, if you need to know another rule for ileostomy, we do ileostomy sometimes, or loop ileostomy. We do it for patient and I did an operation, a definite operation in the colon, and I did a colocolic anastomosis. Okay?
Okay. So you want to relieve any passage of stool through the anastomosis. So you will
Exactly,
do
for 3 months, if I have this one, this is just for your information, and this is the area, and I removed a tumor here, and I make anastomosis. Okay, so I want to keep this anastomosis and to preserve it and to take care about it, not to make a fistula or not to disturb it, by making what's called a loop ileostomy. So all discharge will be here, okay, and I can just relieve this from any for 3 months till I have a good till I have a good yes, good healing, so I can go. Okay, doctor, why we didn't do a loop colostomy?
For me,
No, anyone should ask me why we didn't do a loop colostomy. I didn't do a loop colostomy because I don't want to disturb. Okay, I make here anastomosis and I did a loop colostomy. Okay, there is some ideas tell you that you are disturbing the blood supply of the wall of the colon. But the more important factor, when I go to close the loop colostomy, I need to do an ileostomy to preserve this, anastomosis. Okay, so how I am just want to preserve this to do another one here. What is the idea? So why you didn't close from the start? Okay. So I'm not doing here because I am just going in a vicious circle. I'm doing a resection anastomosis in another part of the colon. So when I close it, I have to take care about it by a loop ileostomy for 3 months. Is it clear?
Yes, it's clear.
Sometimes we do even loop ileostomy for patients with total proctocolectomy, and I did what's called J pouch. Okay, I did a J pouch with the anus. This is the J pouch. Okay, I did total proctocolectomy for a cancer, low anterior resection for a cancer colon or a metachronous cancer through the colon, and I make anastomosis here with a circular stapler. Okay, and then I want to relieve this. I do a loop ileostomy on the right side also as well. This is another indication for your personal information out of our scope.
I'm sorry for asking too much, but you know that I'm also, so I don't have any idea.
I know. No, I know, no problem. But just I don't want to confuse you with many, because I'm a general surgeon, so I don't want to confuse you with many ideas. But just for your general idea, why I do and why I not do, just hear it and forget about it. Okay, next question. I forget whom.
Dr. Abu Yazid, I think.
Dr. Abu Yazid. He seems to be sick today.
He's muted.
Yes, I'm cough too much.
Yeah, just take care. If you want to stop participate, okay, go.
No, I'm fine. I hope it's not corona.
No, inshallah ما فيش يا inshallah. سلامات دكتور أبو اليزيد.
الله يسلمك. 19-year-old female present with colicky abdominal pain, bloating, and alternating constipation, diarrhea. Her grandmother died from colon cancer at age of 87 years old. A digital rectal examination and general physical examination are normal. What's the best course of action? So the age is too young for cancer. So
Yes.
it's a measurement of fecal calprotectin.
Calprotectin, exactly. This patient is a young patient, 19 years old. And he tells you that her grandmother died from a colon cancer at the age of 90. Okay? The same like he tells you her grandmother died in a car accident. So you forget about that.
Mhm.
You understand me? If you ask about patient and he tell you my grandmother, my father or something died from cancer, at what age he tell you at 70, 80, 90? It's very common to have this cancer in this age. Our concern about cancer is the cancer that happened in early age, in 13s or 14s, in the fourth or fifth decade. Okay, this is our main concern in medicine, to hear in normal in UK and other European country, in any other foreign country, and patient dies from cancer in young age, it is something needs to be investigated and concerned about, and you have to make something like survey and screening for all family members. But she died about 87 years. She died with cancer. Yes, it's like she died in a car accident. So just forget about it in this scenario. So a patient has some alternative constipation and diarrhea. So you go for start for the simple non-invasive investigation, which is measurement of fecal calprotectin. Okay, and you may discover ulcerative colitis, Crohn's disease, maybe some like cancer or something like this. But barium enema, colonoscopy, proctoscopy, sigmoidoscopy, all these are invasive and we will not go through. Okay.
Yes.
Next question, Dr.
Okay.
Yep.
22-year-old lady has a long history of severe perianal Crohn's disease with multiple fistulas. She is keen to avoid a stoma. However, she has a progressive disease and multiple episodes of rectal bleeding. Colonoscopy show rectal disease only, and the small bowel study show no involvement with Crohn's. What's the best operative strategy? Multiple fistula, I think it's a complicated case, so we'll go for pan-proctocolectomy with ilioanal pouch.
Yes.
Sorry.
Pan-proctocolectomy and ilioanal pouch.
She have old lady has severe perianal Crohn's disease with multiple fistula. She is keen to avoid stoma. However, she has progressive disease with multiple episodes of rectal bleeding. Colonoscopy shows rectal disease only, and only a small bowel study shows no involvement. Okay. What do you think?
Proctectomy and endostoma. I don't know.
Exactly. Okay. Here is a scenario tells you that the colonoscopy show rectal disease only. Rectal disease only. For Crohn's disease, it is very common to go for segmental resection, even if you did it multiple 1, 2, 3 times. As long as it is segmental part, you can just do it. Okay. In ulcerative colitis, segmental resection is not a common practice. Segmental is not a common practice. So, if in our choice abdominoperineal, not only for cancer, pan-proctocolectomy. Why pan-proctocolectomy? For just only rectal disease only. He wants to say it is rectal disease only. Loop colostomy, for what? There is no obstruction. Subtotal colectomy, Subtotal colectomy, that means that you go from right till transverse till the colon to the splenic flexure. So you didn't remove the pathology. So here you just do proctectomy and stoma. Okay.
But why here she is keen to avoid a stoma?
And she's young age and she don't want to make a stoma. But he tells you here that she have multiple fistula. Remember when I told you patient with a high fistula and complicated not closing fistula, sometimes you go for Hartmann and endocolostomy till the fistula relieved and then make it again. Here I'm doing a proctectomy. I have two choices. Even I do an endostoma, which is endocolostomy, or I go for coloanal anastomosis. Is it logic to do a coloanal anastomosis here with multiple fistula? The patient has in the anal canal multiple fistula. It is infection, multiple infection. I can go for a coloanal anastomosis.
No, it's conditional. You will
No,
do
I can't
stoma.
go for that. I do stoma, so I can relieve the ulcers or the fistula, and I can make setone, or I can just make any operation, or just I deprive this fistula from fecal matter, so it may resolve.
Yes.
So I'm now trying to fix two problems. The first problem is the rectal Crohn's, and second problem is multiple fistula. The only solution to resolve this is that I remove the rectum and make endocolostomy and wait for 3 to 6 months till the multiple fistula get relieved, and then go for definite treatment with coloanal anastomosis. كده دكتور وليد اتفضل.
انا عايز سؤال بره هو مش ممكن يعمل بول ثرو حاجه زي دي؟
يعمل
بول ثرو
pull through in infection in fistula? No.
ما فيش برضه.
لا، في عندك infection multiple fistula, multiple chronic infections.
يعني انا بقى متخيل ان الفيستولا كده يعني ليمتد على الريكتم والسيجمويد مثلا، ما بيبقاش لفوق، فمتخيل ان اللي فوق سليم.
ماشي اوكي.
بس ريسكي ان هو
انت شايل الريكتم كله. شايل الريكتم، تعمل بول ثرو الايه؟ انت لابس في الانس، لازم تعمل كولو انال انستموزس. Get the idea?
Yes.
Okay. Next question. Dr. Shi.
A 56-year-old man presents with his first attack of diverticulitis. Which of these complications is least likely to ensure? Formation of colonic stricture, malignant transformation, development of colovesical fistula, formation of pericolic abscess, formation of phlegmon.
I answered this question.
So, least likely. So, E, formation of phlegmon.
No, I answered this question since a few minutes or half an hour ago. What is, I said that diverticular disease is least likely to go for
malignancy, malignant transformation.
Yes, exactly. Diverticular disease is some sort of weakness in the wall of the sigmoid because of high pressure. It is not like metaplasia or dysplasia or something like this. Just weakness at the wall. It lets the mucosa protrude through the small openings of the perforators or the neurovascular bundle perforation through the sigmoid from chronic constipation. So just it is a mechanical problem. So malignant transformation is very rare to happen due to diverticular disease. Okay.
Okay.
Dr. Fatima, you can go. Dr. Zena is off. Okay, unmuted. Dr. Fatima, you are unmuted. You can go. Okay, Dr. Dafir, go.
A 34 years old lady presented with general practice with the pre-anal discomfort, the general practice discharge pruritus NA, which of the following is least association with this condition? Hyperbilirubinemia, anal fissure, leukemia, sepsis, TB.
Exactly. TB is
Least.
like to do, yes, to do perianal discomfort. Next question.
Previously well, 21-year-old man is admitted with 2 weeks history of diarrhea and passage of blood and mucus rectally. He has previously undergone an ileocecal resection in the past for inflammatory bowel disorder and take methalazine. What's the most likely underlying cause? It's ulcerative colitis. A.
This patient has a segmental resection,
Or Crohn's.
ileocecal resection for past history of inflammatory. Yes, we don't do segmental resection for ulcerative colitis.
Yes, مظبوط.
Okay, so segmental resection here is the key for this 2-week history of passage of blood and mucus, and he did. It is very common. Recurrent Crohn's disease is very common. One of the most complications of Crohn's disease is the recurrence. You remove one part, that's why it is accepted to do segmental resection, because after 1 year or 2 or 10 years, you'll go a segmental resection again. So the key here is he did an ileocecal resection for an inflammatory bowel disease.
Yes.
So the ileocecal resection, you should remove inflammatory, and he did an ileocecal resection for Crohn's disease, and he's taking methalazine. What's the most likely underlying cause?
والألسر colitis كمان مش بيأفكت الإليوم على ما أظن.
Yes, exactly. Mostly in the colon. Crohn's disease is the terminal ileitis. The most common site affected by the Crohn's disease is the terminal ileum, and the most common part removed is the ileocecal resection. The most common part removed by segmental resection is the ileocecal part. Okay. So recurrence is very common in. So this is Crohn's bronchitis. Next question.
20 years old male presents with a discharging sinus in his natal cleft. He's found to have a bilonidal sinus, which statement is false. Can occur on webs of fingers and the axilla. Yes. After drainage, bilonidal abscess should not be primary closed. Yes. A rare complication is squamous cell carcinoma. No. In a patient with acute abscess, the Bascom procedure is the treatment of choice. I don't know what is the Bascom's procedure.
Bascom treatment, it is an open a procedure to remove the surgical removal of the fistula tract was part of the skin. What we do for piloneedle abscess? You didn't see an operation for piloneedle, a wedge resection we remove, and it is not a common practice for infected abscess to do an operation.
Treatment involve excising or laying open the sinus tract, yes. Or maybe a rare complication is squamous cell carcinoma.
Sorry?
Maybe a rare complication is squamous cell carcinoma.
I sent the picture of vascular operation on the Telegram group. Okay. In acute abscess, any abscess, you are not allowed to do.
Just a drain.
You are not allowed to do an operation. You can't, even if it is, you can remember what's called species abscess. You just drain and deroofing and removing of the cyst. You can't remove the species cyst itself. Any abscess, you just drain the abscess.
So it will be D?
It will be D.
Yes. I saw the picture now.
Did you see? This is a past compression. A wedge resection. Sometimes you make it open and sometimes you just close it away from the midline. And it is not a common practice to do it with abscess. But it's a rare complication of squamous cell carcinoma. Yes, rare complication. Any chronic infection can go for squamous cell carcinoma, but it is rare with the piloneedle cells. Okay. This is the piloneedle. Okay, I think this is the last question. I hope so. So, who's next? Dr. Shi.
A 23-year-old lady presents with a posteriorly sighted fissure in ano. Treatment with stool softeners and topical GTN has failed to improve matters. Which of the following would be the most appropriate next management step? So, I'm not sure, maybe D? Endoanal advancement flap?
I said for in fissure, in ano, we have 2 steps according to the UK, and there is policy. They start with GTN or diltiazem, which is a calcium channel blocker and dilator, arterial dilator. If this failed, they go for
injection of botulinum toxin.
Yes, Botox. You know the Botox? This is Botox injection. This is Botox injection to the idea to relax the sphincter because the continuous and chronic spasm makes constipation and decrease the healing rate of any fissure, and it is painful in itself. The pain is coming from the spasm of the sphincter, anal sphincter. So botulinum toxin, makes paralysis, some sort of paralysis for the muscle of the inner sphincter to relieve the obstruction and relieve the pain. And this is the idea of Botox injection, by the way. This is the idea of Botox injection in the face and in the hands and in every place. Make some sort of neuroparalysis. Okay, this is a toxin.
Dr. Amir, sorry, what is this endoanal advancement? Is also for the treatment?
Endoanal advancement flap. We do it for large fistula and high fistula.
But not for this case.
Advancement flap. No. Advancement flap, we do it. It is an operation for fistula. Okay. It's a big operation. You just do a flap to cover 2 flaps together. If it's a fistula tract, you can't close. And if it is recurrent fistula, You just take a flap from the rectum and like duplication of the flap, so you can try to obstruct or disturb the fistulous tract.
اوكي
بتطبقها على بعض كده، بتطبق حته على حته كده، بتقطع حته من الريكتم وتعمل لهم دوبليكيشن كده فوق بعض، بلايكيشن.
تمام
اوكي.
تمام.
Next question. Who's there? Dr. Fatima left for connection issue, so we go for Dr. Dafir.
Just a minute. Okay. A 53 years old man has 1 centimeter polyp identified and completely removed during colonoscopy. Histological confirm a low-grade adenoma. What is the following? What is the correct follow-up? Suggest participate in the bowel cancer screen, but no further routine endoscope. Repeated endoscope 5 years. Repeated endoscope 3 years. Segmental resection of the affected segment. Barium enema 5 years. So it is 1 cm. Has 1 cm in 3 years. Repeated endoscope in 3 years. C.
So it is a low grade,
Yes.
1 centimeter, and a low grade.
Yes.
According to the new protocols of UK 2020, just suggest participation in the bowel cancer screening, but no further routine endoscopy.
Just a minute.
Okay.
This is also changed.
This is change it.
Yeah.
Okay, we have another question also here. This is the protocol. Okay. This is the protocol for cancer. Dump and incurate stick 2 months. On-off surveillance for safety. No high risk finding in baseline colonoscopy. Nothing. Okay, this protocol somewhat confusing. You just know the 2 questions what we mentioned here. This is less than 1 centimeter and only 1, and with low grade dysplasia. So just he will go for the normal, because they always start the screening program for colonoscopy, I think at the age of 55, and this patient is 53. See, he will go for the normal screening program for colorectal cancer. Okay.
Yes.
Okay. This is the new protocol of 2020. Let's go for the next question. I'll pass this question for the next one and then go back for it. Okay, you can read the next question as well. Okay, lead Dr. Abu Yazid, so we can finish the last 3 questions. Dr. Abu Yazid, go. This is the same protocol, by the way.
6-year-old lady is investigated for abdominal pain. A polyp is identified at the proximal descending colon. 3 small polyps are also noted in the sigmoid colon. The largest lesion is removed by smear polypectomy, and the pathology report that this polyp is low-grade elective dysplastic adenoma measuring 3 cm in diameter. يعني هم 3 وأكثر من 1 سم. 4 سوري.
4 وفيهم واحدة 3 سم.
طيب يعني this old one المفروض إنه يعمل re-endoscope in 1 year.
Okay.
So this one is المفروض repeat endoscope in 3 years.
The remaining lesions are ablated by the surgeon. What is the correct management here? 3 years.
Yes.
She is in the high risk group
2020 guidelines.
2020, but they make it 3 years, not every 1 year. Okay. I can't remember the last protocol. Maybe it was about more than 3 or
last protocol
more than
1 polyp less than 1 cm, 5 years. 1 to 3 polyp one of them أكتر من 1 سنتي 3 years. 4 polyp 1 year.
Okay.
ده الأولد.
Forget about this now. Low grade more than 1, go for 3 years.
Okay. Yes.
Less than 1 and less than 1 centimeter, just
Nothing to
go
do.
for nothing to do. Okay. So this
Okay.
is the 2 questions about the new protocol. Okay, last question, Dr. Ihab.
A 67 years old man has a multiple episode of fever and left iliac fossa pain. These have usually resolved with a course of intravenous antibiotic. Is admitted with a history of increasing constipation and abdominal distension. A contrast X-ray is performed, which shows flow of contrast to the sigmoid colon. Here, the contrast flows through a long, narrow segment of colon into a dilated bowel, proximal bowel, which is the most likely cause. I think this is diverticular stricture.
Okay.
Yes.
Yes. What is the scenario here? This is an old patient with episode fever and left iliac fossa pain. So this is attacks of diverticulitis. Okay.
Yes.
There is usually resolved with intravenous antibiotics. So this is the Henshi 1 scenario, and it is relieved by conservative treatment. He has met with a history of increasing constipation and abdominal distension. A contrast X-ray performed shows flow of contrast to the sigmoid colon. Here is contrast flows through the long narrow segment of colon into dilated proximal part. So it is
Diverticular restriction.
Diverticular restriction. Okay. So here he told you about the left iliac fossa, recurrent pain and fever. He wants to direct your thinking to the diverticulitis and diverticular disease, so you go for a diverticular restriction. If he wants you to direct your thinking to a malignant, he will tell you what's called the prodromal symptoms of
Weight loss.
cancer, like nausea, weight loss, slime, passing blood sometimes, anemic, hypoproteinemia, loss of weight. He will give you symptoms. Scenarios will be clear in the exam. Just keep your thinking is very surface, very smooth. Don't go for it is maybe tricky question. A tricky question in the exam is very few to say. Okay, so if you want to direct you to a cancer, he will tell you frankly weight loss, anorexia, some blood, rapid loss of weight, rapid progressive obstruction and constipation. But here the scenario is clear about diverticulitis and diverticular disease. Okay, thank you. We finished colorectal cancer. I think it's less than 2 hours, by the way, because we have about 40 minutes discussing without recording. I'll close the record now. Thank you for you all.
Thank you, Dr. Rami.
Thank you, Dr. Rami.
Thank you.
Thank you for all. Thank you for Dr. Rami for this session.
Thank
Thank
you.
you, Dr. Daf.